This is Dr. Howard Strassler with a Hints from Howard Problem Solvers, Conservative Treatment of the Anterior Worn Dentition with Direct Bonded Composite Resin. We see tooth wear due to non-carious destructive practices, whether it be attrition, abrasion, abfraction, erosion, idiopathic lesions, or multifactorial. And here we're looking at images showing us examples of erosion, examples of attrition in the anterior and posterior arches. We're going to focus on attrition. Attrition are lesions of the worn dentition. As you can see in the image on the upper right hand side, we can see worn maxillary incisal edges, or mandibular first molar, where we see wear on the buccal and lingual cusps, creating these pothole lesions. And so in the anterior, we see wear from the incisal edges, eventually wearing through the enamel, leaving exposed dentin. In the posterior, it starts as a pothole lesion on the posterior cusp tips, especially the first molars. And what we see is these lesions are not self-limiting. Once we've gone through the enamel into the dentin, and the dentin starts cupping out, and you can see how the dentin's cupping out on these maxillary incisors, it's not straight across, that the enamel continues to fracture, the dentin continues to wear, and it becomes a recurring cycle. As our older patients are keeping their teeth longer, we see these conditions, and we need to intervene sooner rather than later. So, how do we characterize this anterior wear? Well, we characterize it by enamel loss at the incisal edge, eventually leading to exposure of the dentin. As the enamel continues to wear, the dentin wears at a faster rate due to both two-surface and three-surface abrasion. It continues to wear, it's not self-limiting, and it can be accompanied by incisal edge discoloration as the dentin picks up stain. It may or may not lead to dentin sensitivity. When we characterize the mechanisms of tooth wear, we can characterize them as being two-body wear, enamel wear, and you know it as attrition, where the patient is bruxing or clenching, enamel to enamel wear, until eventually we wear through to the dentin. When we see wear to the exposed dentin, it's usually three-body wear, where the tooth surfaces, the dentin is exposed, and a third component comes into play. It's no longer enamel against enamel, but rather the abrasive food particles causing loss of dentin, causing the dentin to be cupped out. In fact, if you were to check occlusion, you'd see no occlusal contact on the dentin, but you'd see it on the enamel. It continues to progress until eventually we lose tooth mass, tooth occlusion, and we see supereruption of teeth or shortening of teeth. And a good way to characterize it is we buy a new set of Crayola crayons. We look at them, the tips are just perfect. View that as the incisal edges when the teeth first erupt. Over time, as we use these crayons, as we use our teeth, as we have parafunctional habits, we get loss of crayon of tooth surface. It becomes wider, until eventually when we have significant tooth loss, where if these were the incisal edges of mandibular incisors, we may be all the way down into the cingulum area, where we have dentin exposed. So, what are the typical lesions of attrition? Well, for a very old patient, we may see significant attrition and wear, with loss of significant enamel leading to loss of dentin. Typically the enamel wears, and we see incisal edging chipping in normal function. Initially we may smooth it out with discs, but after several years the teeth are getting shorter and the lesion is progressing. In some cases we can smooth it, and here we see an initial lesion of loss of enamel where we've not yet reached the dentin on the lateral incisors, but we're just barely into the dentin on the maxillary incisors. or more significant wear where we have exposed dentin, and in the case of a patient with an oral habit, we may see it picking up stain, whether it's due to coffee or tea ingestion or smoking. Or we can get even more significant wear, as we see in this premolar, where a patient has lost their posterior stops. Their only function is on the premolar occlusion. Or severe attrition, where the loss is so great we can even see where the pulp chamber used to be. For these cases, we're talking about significant prosthodontic solutions. And so when you're treatment planning, how do you handle enamel chipping? Enamel chipping with dentin exposed, or significant existing restorations with caries and fractures, or severe wear? Well, for me, when treatment planning, when it's enamel chipping with no exposed dentin or very little exposed dentin, I can smooth it and polish it with discs and rubber abrasives. As we have exposure into the dentin, and we can see the dentin being exposed, that our solution may in fact be an adhesive composite restoration, and that'll be the focus of this presentation. As we see more significant wear, that the solution may be prosthodontic treatment, and or perhaps even bonded porcelain veneers. So what this presentation is going to review is, for the initial lesion where we've got an exposed dentin, how can we treat with an adhesive restoration to reduce the wear and delay the need for a fixed prosthodontic solution. And so this is our typical case where we've worn past the enamel into the incisal edges. We have dentin exposed. The dentin may have picked up discoloration. In fact, the patient may notice it, or a significant other may notice it, based upon the fact that they see discoloration. It is an aesthetic. Can something be done? Well, the sequence for restoration of these cupped out dentin areas is using very small burrs to prepare the teeth. First, we need to check occlusion and see what we're doing. The goal is not to build up the incisal gingival length of the teeth, but rather to restore it to the current occlusion. We're going to shape and smooth the tip, smoothing chipped enamel with medium grit abrasive discs and rubber abrasives. Our intradentin preparation of the cupped out areas will be to a depth of a minimum of 1 millimeter. We'll use magnification, and usually there's no need for anesthesia. We're using small burrs. My preference is to a number 1 or a number 329 burr. One could also use a 330 burr. I find also that smaller diamonds work effectively and create less chipping and cracking of the enamel. We restore with an adhesive wear-resistant composite, where we'll need to do very minor finishing. And then once again we check the occlusion when we finish, to not establish new occlusal relationships, but to hold the existing one. So we're going to place a dental dam. It is a difficult placement because in most cases these teeth have no incisal embrasures or posterior embrasures. We're going to smooth with a medium disc and then polish with a rubber abrasive to remove and smooth the rough enamel. And here we're looking after the polishing. We've removed all chipped enamel and left a more intact enamel that we'll be able to establish a cavo-surface margin to. We're then going to do our preparation using small burrs into the enamel to a minimum depth of 1 millimeter. My preference is a 329 burr, which is 1 millimeter in length. 330 burrs can be anywhere from 1.5 to 1.8 millimeters long. As I said, today I'm tending more towards diamonds, so I'm not creating any chattering effect on the enamel and fracture, as we see with the enamel that's fractured on the mandibular left central incisor. And here's our preparations. These preparations were done without local anesthesia. The patient had no sensitivity. I then etched the teeth for 15 to 30 seconds. This is sclerotic dentin, and sclerotic dentin should be etched for a longer time than young, more vital dentin. I etch the teeth, and keep in mind our bonding will be with this intra-enamel preparation. We've removed only the dentin. We rinse and dry the teeth, and then we apply our single bottle adhesive. And when I'm applying the adhesive, I'm using a brush because I can adequately apply the adhesive in. I then blow air to air evaporate off the solvent, and then I restore with composite resin. I prefer an etch and rinse adhesive, although since this is prepared enamel, you can use a self-etch adhesive. I place my composite, and then I'm not building the teeth to be longer, but I'm just shaping the composite to the cavo surface margins. Once the composite's been placed, I then place my light at right angles to each restoration as close as possible, and I light cure each restoration for 10 seconds. I'm light curing the adhesive and the composite simultaneously. I then polish the composite. I can use discs, and in this case I'm using an enhanced finisher followed by a soft flex disc. I then check my occlusion, and you'll notice that I have occlusal marks on the composite. Keep in mind when I first checked the occlusion, there was no occlusion on number 27. There was no occlusion on the incisal edge of number 25. And so I've reestablished the patient's occlusion. And so here we're looking at a preoperative view of the worn dentition, and then after restoration. And notice that the restoration, the teeth are lighter in color, and they're lighter in color because now the light transmits through a tooth-colored composite instead of the yellow stained dentin. At 7 years, we look at these restorations, and wear is continuing, but we've reduced the pattern of wear. And so the rules of thumb when restoring the worn dentition: evaluate the occlusion. Canine guidance provides the best prognosis. The degree of wear contributes to the treatment decision. Slight wear and chipping with only enamel is tooth smoothing. Slight, moderate wear where we're into the dentin is an adhesive restorative material. And a moderate to severe wear or prosthodontic intervention. And at the completion of treatment, considerations to a post-treatment occlusal appliance. Here we're looking at a maxillary case, and many times the patient can't view what's occurring. They may be complaining about chipping of the incisal edge, or perhaps a bluing of the incisal edge because of the translucency in the enamel. Many times a study cast can demonstrate the degree of wear, showing them a normal cast and one of their own arch with wear. My preparation design and technique is just as I described before. A dental dam is placed, usually no local anesthesia, very small burrs, a 329 burr, going to a depth of at least 1 millimeter, and measuring to make sure it's 1 millimeter. Etch, adhesive, composite resins being placed, light cured, and then finished and polished, establishing for wear resistance, aesthetics, and tooth reinforcement. At the completion, make impressions for fabrication of an occlusal appliance to reduce continuing wear. You've been viewing a Hints from Howard problem solver on conservative treatment of the anterior worn dentition with direct bonded composite resin.